Welcome everyone to our webinar today. We'll wait as people join in. We're so happy to have you all today as we're going to just explore an innovative model for integrative pain management at a pediatric safety net hospital. So welcome to everyone who's joining us. Quickly, as folks are coming in, I'll just kind of introduce a little bit about the Academy of Integrative Health and Medicine. We're a global interprofessional integrative health association working to transform healthcare, body, mind, spirit, community, and planet. And there's a little bit of our timeline, which is continuing forward into the future, and we'll share a little bit more with you about that. Just a reminder as well, we record all of our webinars and we put them on the AIHM Global YouTube channel, so you're welcome to review this recording there as well. And Beth, I'll turn to you for this next slide.
Great, thank you so much, Jess. We are really excited that this year, the Academic Collaborative for Integrative Health, or the Collaborative, merged with the Academy of Integrative Health and Medicine. So we will be on that timeline soon. I mean, it has happened, it's really great. Our organization remains intact as a business unit within the Academy. So this is part of our larger global reach now. And for those of you who may not be familiar with the Academic Collaborative, our core members are national academic organizations, as well as individual colleges that are associated with the 5 licensed integrative health and medicine professions, which I have named on the slide. And our membership also includes organizations that are representing traditional world medicines and emerging professions. And these are professions that are engaged in self-regulation and or working towards future licensure. And with that, I would like the next slide, please, Jess, because I want to introduce our wonderful integrative practice webinars project. This is a long time ongoing project within the collaborative. And you can see that the pictures and the names of those who have been working so hard to bring to us integrative practice, integrative practices to talk about what has worked and what hasn't worked so that we can all learn more and move forward. And we're really excited about today's presentation, which is part of this series. And I'm going to turn it over now to Steve Sina to introduce our speakers. I think that's the next slide. Is that, am I right, Jess?
Oh no, I'll quickly put a plug in here too. I like to remind everyone.
Sorry, Dr. Jess.
That's fine. We have a fellowship program that we are starting. Our next cohort starts this October. So you've got a last minute. If anyone's been on the fence and you're thinking you want to join, you can reach out to us, get on our website, learn a little bit more. We just wanted to share. And there is a little discount if you mention you learned about it here on this webinar. So thanks. And now to you, Steve.
All right. Well, I'm very happy to announce our speakers for today. And the order of the presentation, it seems. We have Dr. Maria Broderick is a developmental psychologist and acupuncturist with a specialty in pediatrics. She is an associate professor and director of clinical education at the New England School of Acupuncture at MCPHS University. Since 2010, she has served as the pediatric acupuncturist at the Boston Medical Center, where she oversees acupuncture training in the Pediatric Pain Clinic. Dr. Broderick holds a doctorate in human development and psychology from Harvard University and a master's in acupuncture and oriental medicine from the New England School of Acupuncture. Next person. Here we have Dr. Laura Goldstein. She is a pediatric psychologist with a focus on pediatric chronic pain. She specializes in mind-body strategies for the management of pain. Dr. Goldstein uses cognitive behavioral interventions and has training in hypnosis and biofeedback. She received her doctorate from the George Washington University and completed her postdoctoral fellowship at Johns Hopkins University. Next speaker. Here we have Christine Naoum-Heffernan. She's been practicing as a pediatric nurse for the last 30 years and has training or specialty training in integrative therapies, including but are not limited to 200-hour yoga teacher training, clinical hypnosis, biofeedback, clinical aromatherapy, Reiki, as well as sound energy, trauma-informed care, and specializes in pediatric pain. She has worked at Boston Medical Center for 16 years and currently works in the Pediatric Pain Clinic as well as the pulmonary, allergy, and neurology clinics. She is a former chair of the Integrative Nurses Council, whose goal is to educate staff and transform the acute care model to include integrative medicine as part of a pain management accessible to all adults and children. She also collaborates to put together an annual integrative nursing conference annually as part of Nurses Week. And the next is, and this will be our next speaker, will be Dr. Caitlin Neri. She is a pediatric hematologist, oncologist at Boston Medical Center, where she specializes in not only pediatric hematology and oncology, but also sickle cell disease and chronic pain. She received her medical degree from Ross University School of Medicine and has been practicing for over 20 years. She has completed her fellowship in hematology oncology at Children's National Medical Center in Washington, D.C., and is an instructor of pediatrics at Boston University School of Medicine here in Massachusetts. So I'd like to welcome Dr. Neri to begin the presentation.
Thank you very much. I just want to thank the AIHM for this opportunity to share our work with you, and most importantly, our team with you. I am so blessed to work with this fabulous team. It's so critical to everything that we do. So thank you for letting us do this in a team presentation. Okay, jumping right in, if you could advance for me. So we're going to talk a little bit about the origins of our pediatric pain clinic, quite a bit about the integrative teamwork environment that we have created, and how we use integrative strategies to influence patient outcomes. If you could advance, thank you, and advance. So Boston Medical Center is our home. We have our clinic here, and BMC, as it's known, is an urban safety net hospital here in Boston, where the vast majority of our patients come from underserved populations. Our clients are dealing with all sorts of challenges. We have many new immigrant families, many families where English is not their first language, and social determinants of health are integrated into the work we do every day. We are also a level 1 trauma center and the teaching hospital for Boston University School of Medicine. It's a 482 bed hospital with the full spectrum of pediatric primary and specialty care. There are about 50,000 pediatric visits a year. And a really special part of the Department of Pediatrics is our 200 children and adolescents who are living with sickle cell disease. So we had this opportunity to offer integrative care for an underserved pediatric pain cohort. When I came to BMC about 8 years ago, I had an interest in putting together a pediatric pain program. And after some initial work, had discovered this wealth of integrative expertise that existed at Boston Medical Center, mainly within the Department of Family Medicine, that had been only sort of minimally tapped into for pediatrics, but there was so much expertise, which is really very unique to have somebody like Maria, who was already working at BMC at the time that I started. And so we had this opportunity to think about using integrative medicine in pediatrics, and sort of set out on this project to develop a pediatric pain clinic. So this is our referral process. Kids are referred to our clinic either by their PCP or by their specialist. It's actually very common for kids to come to us after being seen by many doctors, sometimes a neurologist and or multiple gastroenterologists. And so that's relatively common, that this has been going on a long time and they've seen a lot of providers by the time they come to us. So our initial evaluation is really focused on establishing the team approach and sort of hearing the story from the patient all at the same time. So we all sit together in one room, myself, Dr. Goldstein, Christine, our physical therapist, whose name is Elise, and our social worker. And we hear what's gone on with the patient's pain over sometimes many years, and then complete the clinical evaluations on that first visit. And then subsequent to that, the patient returns usually within a couple of weeks to get started on their individualized pain management plan. And it's on those follow-up days that we build in all of our integrative services. So this slide just describes our referral services, the sources rather. So we see kids that come to us from neurology clinic, absolutely, with chronic daily headaches or migraines. Kids come to us from GI clinic with functional abdominal pain or daily stomach aches. We've seen several kids from genetics with different conditions, some children with Ehlers-Danlos, others with painful skin conditions, all sorts of things. And then we have these 200 kids with sickle cell disease who almost all can benefit from seeing us in the pain clinic. We get many referrals from primary care and adolescent medicine, as well as the community health centers. And honestly, far and wide, you know, people come from all over New England and even farther sometimes to see us in the clinic. And what's very important is the interdisciplinary team. And I say interdisciplinary as opposed to multidisciplinary, because interdisciplinary really implies that there are different expertise, different training, different backgrounds, but sort of the same overall goal. And the close communication between the team members is really critical. It's much different than me seeing a patient in my office and saying, oh, you ought to go try acupuncture, or you should get physical therapy. It's much different than when we sort of work together in the same space, and the patient sort of feels that team approach and understands that the team approach is critical to their recovery. So our pain management plans incorporate integrative therapies really right there in the same clinical space. So the physical therapy evaluation takes place in our clinic on day one. Sometimes we do refer for skilled PT in the community, because if you're going for skilled PT, sometimes it's like twice a week, and it can be easier to get that close to home. But we sort of keep in touch with the community providers throughout the physical therapy. And then all of the mind-body strategies are delivered right within the clinic. You know, after I do my medical clinical evaluation and update, Dr. Goldstein comes right in and jumps in with her non-farm strategies. And Maria and her acupuncture students are delivering acupuncture right there in the clinic. Our massage therapist as well right there in the clinic. And then Christine does so many things. She'll be delivering Reiki or aromatherapy or doing some yoga or some breath work, whatever she sort of decides is the right thing along, you know, in combination with the child and family. And we always say it's not a cookie cutter approach. You don't get the same thing every time. Our job is to just help people explore things that they might find beneficial, and really sort of like take the control back for their pain. And that's all done in a really interdisciplinary way. So our treatment plans are comprehensive. You can see I put medications as number 6, because while I do use many medications to treat persistent pain, to treat you know, different evidence-based approaches for functional abdominal pain, constipation, diarrhea, or evidence-based approaches for migraine and chronic daily headache, or neuropathic pain. It's not the big deal of our treatment plans. The non-pharm is really critically important. Not every patient even gets any medication management, but every patient gets the non-pharm approaches. So often physical therapy is prescribed. Some sort of exercise is always prescribed. We encourage our kids and teens to use yoga and martial arts and other things like that as part of their treatment plan, spending time outdoors and in nature. And then we use a range of integrative strategies. We use acupuncture, acupressure, aromatherapy, massage, Reiki. We also use a variety of behavioral strategies, which Dr. Goldstein will spend a lot of time talking about. And then we do a lot of lifestyle interventions, which we all work sort of together on. Our social worker certainly helps a lot, but we try to normalize the social environment, attending school, meeting up with friends, participating in age-appropriate activities, normalizing sleep, and a good healthy diet to aid in pain recovery. And then we do a lot of family coaching, which a lot of that is done by Dr. Goldstein and also our social worker, but also Christine and myself and Maria doing some sort of encouraging families on how to support their kids in this pain recovery by sort of not focusing on pain, but focusing on the positive strategies that help to recover from pain. So just a little bit about some definitions. Since we're talking about pain, we know that pain is an experience. It's an unpleasant sensory and emotional experience, but there doesn't have to be actual tissue damage if we're talking about pain, versus nociception, which is sort of the neural process of the impulse that comes to the brain after a noxious stimuli. It may raise your heart rate or your blood pressure, but the sensation of pain is not necessarily implied. So if you can just go to the next slide, please. Yeah, so we don't mind pain as long as it doesn't hurt. So that we do a lot of education with our kids and our families to teach them that 100% of the pain that you experience is produced by the brain. And so we can sort of use that strong connection to use the mind to sort of dial down the pain experience that we feel. And there can be some medications that can help with that process, but a lot of it is these mind-body strategies and non-pharm approaches. So the types of pain, if you could just advance for me, there's acute pain, which is when that's like big pain. There is a tissue injury, the candle is burning, such as from inflammation and injury and infection. That's what we're talking about when we talk about acute pain. And next is subacute pain. So that can be an ongoing cause, so like a smoldering pain, not this big acute pain, but there is some ongoing nerve tissue injury and the candle is still burning in some way, like a chronic infection or an arthritis. Then there's chronic pain that's not associated with tissue injury. So this is the vast majority of what we're taking care of in our chronic pain clinic. And this is when the pain persists after everything is healed up as best as it's going to be. Next, please. And then there's these acute on chronic pain. So that can be recurrent episodes of tissue injury, such as somebody with recurrent sickle cell crises or somebody with inflammatory bowel disease and recurrent flares, where there are these recurrent episodes of acute pain that starts to take on a more chronic appearance. So these, if you could advance, these two here on the right are really what we're taking care of in our chronic pain clinic. It's generally a very long-term problem, and we always tell our families that a long-term problem requires a long-term solution. So we're not going to wave our magic wands, but something that's been going on a very long time takes some time to correct. But if they stick with us, we usually have pretty good luck. Go ahead. So chronic pain is extraordinarily common in children. Conservative estimates have suggested that up to 35% of American school children are impacted by chronic pain. And the vast majority can be attributed to one of the following. chronic daily headaches and migraines, chronic abdominal pain, and musculoskeletal pain. And that's really the vast majority of what we're taking care of in our program. So definitions can be challenging when talking about chronic pain in kids. You know, it can be described as just lasting beyond the usual course of healing. Sometimes you'll see time definitions of, you know, up to more than 3 months or more than 6 months. You can also just say pain that continues when it ought not to. And you can also classify it by its pathophysiology, meaning the functional changes resulting from the disease, which can be nociceptive, like ongoing tissue injury, or can be resulting from neuropathic mechanisms where there are functional changes in the nervous system, which lead to the continued experience of pain, or it can be a mixture of both. So there really is a biopsychosocial framework to understand the pathophysiology of chronic pain. There are often biological changes, sometimes an injury or an illness that can be the trigger. There are sometimes genetic predispositions. We see chronic pain run in families for reasons that are incompletely understood. And then there are a lot of social factors that are at play where the child or teenager withdraws from family, school, things they used to enjoy. Their parents play a crucial role, the parental response to pain, their own emotions, cognitions, and behavior, and also peers obviously play a role. There are psychological factors involved in the pathophysiology of chronic pain, our emotions, thoughts, behaviors, and any psychological comorbidities can also be involved. And with that, I'll turn it over to Dr. Goldstein to speak more about the psychological and social risk factors and strategies.
Thanks, Dr. Neri. Thanks for having me today. So I just want to kind of tag on to what Dr. Neri was saying related to all the factors that can contribute to pain. You know, we know that all, you know, there's so many family factors and social factors. We've seen kids miss numerous days of school or even months of school due to, you know, fears about attending school with the pain, or bullying, or just social isolation. And then the psychological, which I'm going to talk a lot more about, you know, how kids cope with not just with pain, but with general stressors. You know, that can be a big factor in managing pain, because pain is a significant stressor. And just their history of anxiety and mood issues, stress in general. And then this family history of pain, it can be a really big one. We see, you know, numerous families come in who have a long history of chronic pain. And, you know, that can be a lot of modeling that, you know, this child is growing up with, is seeing their parent or guardian in pain and how they're dealing with it. And then we have a lot of health habits that we address. Sleep is one of the biggest ones that we tend to address first. A lot of our studies have shown that, you know, majority of our kids have really significant sleep dysfunction. So, you know, really focusing on that to get them back on track, and then a variety of other factors, including diet and physical activity. So you can advance. So in terms of the psychological factors, there's been a lot of studies that have shown that, you know, kids with chronic pain have, you know, significant symptoms of, or, you know, it has been associated with significant symptoms of depression. And that can go either way. You know, that can be a history of depression, or, you know, and then they're more susceptible to this chronic pain presentation, or they, you know, have this chronic pain and that can lead to more depression. And, you know, there's been numerous things that are related to depression, including sleep issues. academic problems, the social problems. Again, we see this maladaptive coping, and then a number of our kids come in with very high anxiety, either related to the pain or otherwise, but it typically contributes to worsening pain. Kids may end up avoiding feared places due to having had pain experiences there or not, but they are afraid of having pain in those situations, or the pain increasing, and so they end up avoiding social interactions. They end up avoiding school, and one kind of feeds the other, so it does become this really entrenched cycle. You can advance. As we mentioned before, it does tend to run in families. Kids are experiencing psychosocial issues, academic problems, and a lot of changes in their mood and behavior with this chronic pain presentation. You see a lot of high levels of parenting stress. It's a very stressful interaction to have to deal, and manage, a child who has chronic pain. It's a daily thing, and a lot of these parents are trying to get their kids to go to school and to do all these things, and it can be a real struggle. And a lot of these kids end up falling into this sick role, where they're the kid with pain, and parents just have a hard time knowing how to respond to that, and can inadvertently end up feeding it as well. It also creates a financial burden on the families, missed work, and having to bring their kids to multiple appointments. So, as we're talking about, the psychological piece and how to kind of manage this pain, a lot of what I do is non-farm strategies. So relaxation-based strategies, and part of it is, educating kids and families to, for them to understand why we're doing this, that there's actually scientific reason why this is important, and that, these messages are being sent to the brain, and stress actually increases the pain presentation. And so, a lot of is kind of just setting up that foundation and then giving them the strategies to practice. So I do a lot of diaphragmatic breathing, or deep breathing, meditation, progressive muscle relaxation, which is basically progressively tensing and relaxing different parts of your body. A lot of imagery, and then I am trained in biofeedback, which is using information from your body to basically be able to show how stress affects the body, and so that they can use these strategies more effectively at home and see, oh yeah, when I do this, it does increase my stress, or when I do this, it does decrease my stress. I'm trained in hypnosis, which is a kind of a deep relaxation exercise, and I'll use a lot of visualization to get kids to be able to kind of tone down what we call the volume of their pain, and also kind of teaching kids and families how to use distraction, so they're not constantly focused on the pain. Another piece of what I do is I use a lot of cognitive behavioral interventions. So getting kids and teens and families to understand how their thoughts contribute to their feelings, which also contribute to their behaviors. And so with pain, what often happens is you have some sort of sensation in your body, and it's interpreted as something awful and terrible, because that's how we see pain. And so there must be something wrong. And so they end up, developing a lot of anxiety, a lot of hypervigilance about their body, interpreting every little sensation as something that could be wrong. And, with those thoughts come a lot of, feeling down, feeling anxious. And these feelings, again, contribute to this cycle. So it can be a feeling contributes to avoidance behavior, or increases certain thoughts. But again, it's that cycle, and getting kids and families to understand how this cycle is contributing to their chronic pain presentation. So with that, I do some cognitive skills training. So getting kids to kind of link their thoughts to their feelings, and understanding that sometimes these automatic thoughts pop into their head, when they feel these sensations, and what they can do at those moments in order to kind of challenge those thoughts or reframe those thoughts. Doing a lot of more positive self-talk. This is a really good workbook for kids and teens that actually that I use some exercises from. And then another piece is the behaviors. So because they often end up avoiding certain things, and that feeds the pain, part of what we do in our clinic is really trying to get them back to those activities. And so that could be increasing physical activity, that could be slowly getting them back to school, just being able to get them out of the house and doing things that they enjoy. We do a very slow approach to going back to school. I work very closely with the schools, myself and the social worker, getting kids to kind of attend part of the time, a couple hours, a half day, a full day. So doing it in a very slow fashion. And then doing a lot of positivity, focusing on, their functioning, focusing on what they did well, and giving a lot of reinforcement for that. And then a big part is the parent intervention strategies, is getting parents to understand that this chronic pain presentation is very different from having a kid with an acute pain presentation. When your kid is ill, you're used to just, support, giving them a lot of attention, having them sleep in, giving them lots of different things to make them feel comfortable. And that's exactly the opposite of what we want these parents to do. While we want them, of course, to be supportive of their kids, we also want them to not focus on the pain, and we want them to encourage functioning. So with that, we always, make sure parents reinforce to their kids that this pain is real, that we believe them, that it's something that they're really experiencing, but that doesn't mean that we, that we're not doing things and we're not trying to get up and moving. And so we tell parents, really try not to ask kids about their pain. We talk about pain in the clinic, but outside of the clinic, it's really about what can they do to help their pain, what can they do to make it better. And so we're giving, parents, kind of empowering them to help their kids in that way. We also encourage them to use, positive pain coping themselves, because a lot of these parents are dealing with their own pain issues, and encouraging good sleep. And then just focusing on that this problem is going to take a while. Like Dr. Neri was saying, it does require a long-term solution. And this right here is a really good book that we hand out to a lot of our families. When Your Child Hurts by Dr. Coakley at Boston Children's, one of our colleagues. And now I will turn it over to Maria.
Thank you, Laura. So BMC welcomed acupuncture actually back in the early 2000s into pediatrics. We started a decade prior, as Dr. Neri referenced, offering acupuncture prior to the launch of the Pediatric Pain Clinic. And it's a really interesting story, actually, how pediatric acupuncture got started here at BMC. The door was first opened, actually, via a program called Healing Landscapes, which was a Ford Foundation-funded initiative that was housed in medical anthropology at the BU School of Medicine. And it aimed to make forms of traditional medicine accessible to BMC patients who desired it. And so pediatric acupuncture was launched under that umbrella of the Healing Landscapes Project. And that was the point in time at which the New England School of Acupuncture began partnering with BMC to deliver acupuncture services. At that time, NISA did have other relationships with other hospitals and community health centers, but this was the first initiative that NISA launched in partnership that was focused on a pediatric ambulatory clinic. And it gave our students their first access to working side by side with hospital personnel. It was first launched actually in the adolescent outpatient clinic and then later expanded in 2004. We were in adolescent medicine, and then late 2005, we actually were able to work inpatient, seeing kids with pain conditions under the general direction of the pediatrics program. Next slide, please. And one of the services that we've been pleased to provide over the years inpatient is actually through a partnership with neonatology. We've worked for many years to deliver a form of pediatric medical massage, as well as what are known as, in acupuncture speak, non-insertive techniques. So using tools that are non-insertive to work with neonates suffering from neonatal abstinence syndrome. So that's one of our enduring initiatives. And in the last several years, we've worked with Dr. Alicia Walkman on that program, which was paused for COVID, but we hope to restart. And then next slide, please. As Dr. Neri mentioned, when she was first exploring launching pediatric services as part of the pain clinic, she carried out a needs assessment, and as she referenced, the presence of a sustainable pediatric acupuncture program was viewed as favorable to being able to offer a range of integrative services. Our pediatric acupuncture program had already demonstrated its capacity to attract families, its record of safety, and our ability to put children at ease and introduce acupuncture to them as a service. So we had that foundation laid before the Pediatric Pain Clinic was launched. And as she mentioned, those services are delivered by New England School of Acupuncture interns under the supervision of a preceptor, and I have been that preceptor since 2010. The interns, when we joined the Pediatric Pain Clinic, were then moved. Now the PD Pain Clinic is our primary home here at BMC. And as Dr. Neri mentioned, we're here together in service. In fact, today is one of our integrative care delivery days. So the team, does their initial intake on Monday, and then Wednesday is the day where we're here together to deliver integrative services and also do follow-up care with the patients. NISA is the oldest acupuncture school in the country, and we place our advanced students here for semester-long rotations. Since 2004, we've placed over 300 acupuncture students in pediatric rotations at BMC. So I think it's the longest standing pediatric rotation in the country, and certainly the longest in a safety net hospital. We've delivered in that time frame in our three contexts of care, inpatient, outpatient, adolescent, and PD pain, now over 6,000 treatments. And we have numerous graduates who, really use this rotation as a stepping stone to see children and families in their own private practices. And as well, we have several NISA grads who now have staff positions here at BMC. One of our grads from the Pediatric Pain Clinic is now the staff acupuncturist in family medicine. And we've expanded our services beyond family medicine as well to include internal medicine. So costs to BMC for our services are minimal. Really, they consist of using the existing space available to the pain clinic, as well as scheduling support. But the acupuncture college provides all of the acupuncture supplies, underwrites the salary for the preceptor. And so part of the nature of the sustainability of our program relates to this partnership with the New England School of Acupuncture. I'm just so pleased with the reception acupuncture has received across BMC, and especially in this environment of the pain clinic, where our students have been really made to feel part of the clinic, playing an important role in the care of these children. In addition to acupuncture, we have a flexible set of tools in Chinese medicine, so they also provide acupressure, cupping, gua sha, and Tui Na, which is kind of gentle pediatric medical massage. So we work really flexibly with the families, addressing what the child or teen is comfortable with. No one has to have acupuncture in this service. But for the most part, over many years, we found it to be very well accepted and welcomed by families who've really come to appreciate the wonderful services that our interns provide to them. In 2015, just as a note, NISA merged with the Mass College of Pharmacy and Health Sciences, which is a health sciences university. And through that relationship, MCPHS University has continued to support our placements at BMC here and provide our students with a platform of interprofessional educational experiences, of which the BMC pediatric rotation is an important contributor. So we look forward to an enduring partnership. And I will turn it over to Christine.
Hello. So little typo, I'm not a doctor. I do have my master's, but you never know, maybe I'll go back again. But the Pediatric Pain Clinic is my passion, and I'm really proud to be part of this team. And so I bring the nursing component to this. So I think the first thing that I wanted to comment on is the language. Over time, we've used things like alternative or complementary or holistic, which each has their own connotation. Holism, yeah, we look at the whole thing. Alternative implies one versus the other. But integrative really implies taking pieces of the puzzle and putting it all together. So it is really important that sometimes medicine is needed, but we also know that if we can help our kids by providing not only a medical, but psychosocial, and hit all their needs all the way across the board, that we get these kids in a much better place. So the nursing component that I bring, I do have multiple roles. One is simple stuff, like I run the clinic and make sure it flows and make sure everyone has their appointments and try to make it so the clinic goes smoothly so that we don't have a lot of downtime. Our kids are with us on average for about 3 hours on the Wednesday afternoons. So that can be a lot for them. So if we can keep things moving, that works pretty well. My training, I've got a lot of things, but the things that I bring specifically to the clinic is Reiki. If people are or are not familiar with it, it is a light touch energy therapy that can be done hands-on or hands-off. And basically what it does is we work as a conduit. The energy runs through us and it allows the body to be put into a nice state of homeostasis where the body can naturally heal itself. So I'm not special in magic, no Reiki practitioner is magic. But what we do is put the body in an optimal state of healing. And I think the best way to explain this is if you ever have a cut and you are super stressed out, that cup can take forever to heal. And yet other times, if you're in a good state of mind, you can have a cut and it healed overnight. And we don't question that. So we know that stress hinders the body, and any way that we can help get it in a better place is going to help. So, and in an ideal setting, a Reiki session is an hour, but realistically, either in clinic or if I get called to do an inpatient, either 10, 15 minutes, or if all you have is 5, it's better than nothing. And it really does make a difference. Aromatherapy, I am skills validated. And what that means is I work under an aromatherapist who's done the formal certification training. but we work with, and we've created policies for. And so we have about 6 oils that I will sit down and have the client smell them. I don't tell them what they are or what they're for. And I let the kids smell it, and then I make a blend specific for them. And the oils that we use peppermint, bergamot, black pepper, frankincense, mandarin, and lavender. And usually some combination of those will hit all the things that my team has already alluded to. It helps with headaches, it helps with belly aches, it helps with stress and anxiety. So I don't tell the kids what it's for. I let them smell it, and then their body viscerally decides what they need. And then I go back and say, hey, your body actually chose the one that you actually needed. So then they think that's really cool, because how could they have known? So it just creates more buy-in. Yoga, I think most of the panel here has done some form of yoga. Again, when we do yoga, it's not about doing a full yoga set. It's just about checking in to see where the kid is at, what is going to help them most. Like if they have belly aches, then we might be focusing on forward folds. If they've got a lot of stress and anxiety, I might do balance poses, because that has to create some humor when you keep falling down. Or if they have a lot of tension in their shoulders and neck, then I'll come up with exercises specific to that. I'm also trained in mind-body strategies that supports a lot of the work that Dr. Goldstein does. So I have biofeedback. And again, as it was explained, biofeedback uses instruments and projects the energy on a computer screen. And so then the kid can engage in a game, and that allows them to see, oh, when I'm all anxious, my car's wiping out, but if I can calm down, then I can get control of my car. Versus hypnosis, which is very internal, and some of our kids do better with that. Those kids, we use the mind to help create a safe place, and then we explore the discomfort, breathe into it, try to change the colors and the intensity of it, and then create a frame in their mind, a file in their computer, so that they can come back to this later on and utilize it later. And then, which leads me to education. So I live and breathe pediatrics, so I call it a toy box, right? So toy box, toolbox, whatever you want to call it. But the idea is that we have a bunch of different things in there, so that when the kid is feeling a certain way, that they can pull that out. They might want to do aromatherapy one day. They might rather do yoga another day. They might have that ability to start exploring some of the other skills that are taught with Dr. Goldstein. We have apps for them to use on their phone. The idea is that we keep reminding them to go back, because it's all well and good that they learn a tool, and that's great. But if you don't remember to go back to that tool, you haven't built that muscle. And then the other thing I want to say too is, a lot of times we might see a kid who's really in pain. And so I try to teach them something, and they may not really buy in all that much because they're so uncomfortable. But if we can teach them how to do it, and then I say, go home and practice, 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 the more they practice on the days that they feel good, and they realize, hey, I actually feel kind of good, then they can access that when they're miserable. Okay. So it's about education, it's about reinforcement, and it's about giving them, or empowering them, that they are 100% in charge of their body. And so I'm not going to make them do anything, but I do want them to try it, check it out for themselves. And if they like it, great. If they don't, I'm going to find something else. I think that's good for this slide. Can you advance? Thank you. So these are just some of our books, and depending upon how old your kids are, the Breathe With Me and the Good Night Yoga are really good for your younger population. And then it depends on the kid, but I'd say like probably 8 and younger. They love these books. They're so good. And you can do a quick review with them, show them how to use it, and then the kids will practice it at night. So we give them these books to take them for home. We have a whole handout for apps, which I'm actually going to go back to my team. Are we providing resources? Because I was thinking of a couple of videos that we might be able to provide, and then the apps that we have, I think would be willing to share those as well. So just let me know if you guys want that information. And then we give them handouts to reinforce the education that we've taught them. And yes, I have done lots of stick figures from my yoga poses. Next slide, please. Okay, and then I think Maria is up
Yeah,
next. Oh no, Caitlin, excuse me.
Thank you, Christine, so much. I'll just jump in so we can
Thank you.
finish up and have time for questions. We just wanted to mention that one of the initiatives in our Department of Pediatrics is it's called the Center for the Urban Child and Healthy Family, which is sort of our future direction of our department, where there's a lot of research projects and clinical initiatives. And some of the landscape work had uncovered this desire amongst the participants in the focus groups to have a more integrative and holistic approach to pediatric health and wellness. And so we hope that we're going to be able to serve as a model for ways that this kind of care can be delivered across many different healthcare settings. Going on. Yes, going on. So I am definitely much more of a clinician educator than a researcher, but I just wanted to share one of that. We've done different research projects over the years, but one was when we were initially rolling out our expanding our integrative therapies beyond acupuncture. When we first opened, we did a feasibility project looking at our sort of initial cohort. You can just see here are some of our demographics going on. And there was a number of different clinical indicators that we tracked in this group of 80 or so children. Going on. You can skip this one so we get done. But one thing that we looked at was trying to have a cost effectiveness component to this work. And so through chart review and also family interviews, we documented all of the different medical interventions that had been done. Really in this project didn't even include opportunity costs in terms of parents' time and lost wages and such, but really just looked at the medical interventions and tried to quantify how much that would cost in the year before the child worked with us and in the year after. Going ahead. So this is our sort of our results of these children who worked with us and some of the pain types that they had. Go ahead. And we were able to estimate the cost of, and you can see over on the right-hand column, the total cost for these 83 kids at baseline for the year prior. There's quite a lot of money spent on surgical procedures like endoscopies and things like that, on medications, on hospitalizations, and on consultations with many specialists. Going ahead. And then we were able to look at the year following for at least 46 kids who we had that full year of data on, and saw a really dramatic reduction in healthcare costs in this sort of this sort of limited method that we looked at, which was a sort of a self-report, not a dollars and cents kind of insurance claims data, but these data were based on self-report and chart review. Going on. So our future directions for this clinic is really, like many people in healthcare, we are currently in the process of rebuilding after the effects of the COVID-19 pandemic, which are still impacting us as I'm currently in quarantine at home with my family. But we are trying to sustain this model within our hospital system. I think we've become pretty permanent. We're no longer a pilot. We're sort of well integrated into the department, and I'm not worried that we're going anywhere anymore, although I spent many years worrying about that. I hope that we can serve as a model for interdisciplinary care within pediatrics and beyond, and we hope to grow to meet the demands of our community. Okay, with that, I'll take some questions. I think, yeah, so that paper is still in press, but it was presented at APHA by one of our colleagues who's a cost effectiveness expert and was on our team. Okay, so what else? The resources, yeah, I'm happy to share any resources, that's fine. Models, need more models that can be used in private practice and non-hospital based. Yeah, all I can say is we've been very creative. We have not asked a lot of permission, and we've just forged ahead doing things that we think make sense. And it's worked. So I think the best thing to do is just to try things. You know, we sort of just set up shop saying, I'm going to see patients and Dr. Goldstein's going to be here with me. There's always logistics, like, you know, she bills into psychiatry and I bill into pediatrics. So we have to have the templates done, and how does the billing work, and who arrives the patients. And there's a lot of like logistics, but once you get that set up, it tends to work. Has there been discussion about expanding the integrative team to include chiropractic care? That's a good question. In pediatrics, you know, so we have sent some older I would say adults, young adults, to chiropractic care in the community. We don't have a chiropractor at BMC, and you know, in my most recent review of the data, there's still not enough good data for me to be recommending chiropractic care for children, although it's something I continue to look at. But in general, for adults or older teens, we have sent people to the community. Let me see. Yeah, here's some of our links and things in the chat, which you're welcome to check us out. I don't know if there are any other questions for my other team members, or I'm happy to answer anything else.
We're so close to the wrap up time. I'm wondering if we can pause and thank the team so much. If there are questions that aren't answered, please put them in the chat and we will follow up with the team and the Integrative Practice Webinar Project team. This has been incredible, inspiring to know that these things are going on. So Jess, do you want to show our last slides? And
Sure. I know I saw there's a few more questions rolling in right now too. And I know we would love to get to them all, but we probably don't have time. So yeah, I want to say definitely a big thank you to everyone as well. And I'm also sharing, we've got our conference coming up this October, which is completely virtual now. We want to remind everyone that that's, you know, here and available, and I'll put some links in the chat as well, so that you can access the website to learn more about the conference and to register. And then there are we've got some upcoming events. Our next webinar, which will be after the conference on November 5th in SCU sponsored genetics series. We've got Astounding Successes Using Gene Therapies. It'll be the third part in the series. And there's a registration link in the chat for that. And the next AIHM and ACIH Integrative Practice webinar this series will be on November 12th, addressing chronic pain and integrating physical function services into community health centers. The registration link for that is also in the chat. And again, the fellowship is, there's the next cohort starting this October. The following cohort will begin in April of 2022. So if that's something you've been thinking about, definitely reach out to us. Link also in the chat for everyone. And as always, please, you know, stay connected with us, the Academy, on our different social media accounts, and you can join our chapters or Students Alliance and become a member. I don't know if there's anything you want to add there, Beth?
I would like Steve, if you're available, to come on and thank the speakers and team again. This has just been absolutely incredible.
Yes, I've been hearing about their work for so many years through my colleague, Dr. Broderick, and I was really excited to be able to know that they had a chance to speak with us today. So thank you so much for your time and all the amazing work that you're doing with kids here in the Boston area. I'm a Boston area boy myself, so thank you so much.
Yes, thank you for all the work you do and for sharing information in the chat too. We really appreciate that. So everyone, have a great week. Bye.